So the low risk is decided based on molecular markers mainly today. I mean, so what type of molecular alterations do I need to find and do to determine if it's low risk and high risk? And is this done by NGS, next generation sequencing, or some other methodology?
Correct. So the molecular IPSS is actually something you cannot calculate by hand. It has to go into algorithm. And this depends on the blood counts as well as the cytogenetics and the molecular features, as you mentioned. So the molecular features basically are assessed through a next generation sequencing. Most of the kind of big institutions and the commercial tests will have at least 40 to 50 genes. Of those, 17 are incorporated into, or 31 are incorporated into the molecular IPSS. However, you don't have to have all of them. So this tool does account for missing values if you have certain alterations that are not there. Most of these alterations actually have negative prognostic impact. Of course, it varies to what degree. TP53 is very bad, for example. Um, MLL partial duplication is very bad, while there are only very few things that are good prognostically, such as SF3B1. So you put in the molecular features, the cytogenetics, blood numbers into the tool, and it's actually easy to use. It's online. Within 1 minute, you get the number. And what the number that you get is basically a score. If the score is positive, the patient would be higher risk. If the score is negative, patient would be lower risk. And then depending on the specific group for lower risk, since this is what we are focusing on right now, the patient could fall into what we call moderate low, low, or very low. Very low, the median survival could be on 10 years. So patients could live again a decade with very minimal interventions. Where moderate low, the patients are getting closer and closer to the kind of the higher risk disease.